Well, the problem as it relates to these pumps is something that we first described through, I think probably in 2004, 2003 or 2004, we described patients with bleeding from AV malformations in the small intestine. And this was sort of a curiosity. Reviewing the literature, however, that it had been described in the European, the German literature in the 50s with aortic stenosis. There has been an association with the potential for the shear causing a disruption of the molar form of the von Willebrand's factor, which actually makes the patient hypocoagulable. It's unclear whether that is the mechanism or not, but I think it is a real entity. It's just not a very common thing. I think much more has been made of it than actually its impact in the field. We recently reviewed our patients, and we found an instance of GI bleeding in general, about 25 to 30% of some form of GI bleeding in the postoperative period. And it's about what it was in the Novacor experience. And the instance of AV malformation bleeding was about 5%. And generally this goes away. In our experience, it always goes away if you restore pulsatility and simply decrease the anticoagulation or stop it altogether. We frequently stop it altogether. Since there's no element of stasis in this technology, I'm not sure the bulk of the patients need anticoagulants for the pump. The secondary effects of the pump, however, may result in stasis in areas, for example, like the non-coronary sinus. We've seen clots form in the non-coronary sinus because if the aortic valve is not opening, which in general is not opening with this technology, you will have stasis in the non-coronary sinus. So it is an area that we're still gathering information on, but although we do see this GI bleeding in a small percentage of the patients, it is, I think, clinically not relevant to its use. That is, it's not a factor in deciding whether to use the technology or not. Well, it's going down. I think the real problem was in the initial use of this pump is in series with the heart. That is, compared to the Jarvik pump, which is in parallel, which was the original pump that we did most of our work with. But this pump has the same actual mechanism of operation, but it's just outside the heart, so it's in series with the heart. That is, and that means it has a restrictor, the inlet cannula between the pump and the heart. And it actually, as such, leaves a reservoir of blood within the left ventricle, which it turns out is beneficial to the function of the right ventricle, which of course is necessary for the filling of the left. So it is the restriction is of great benefit, but it does not allow, in most cases, the aortic valve to even open. And that means if the aortic valve isn't opening, particularly in the immediate 3 to 6 months after implant, you cannot measure the blood pressure with a conventional cuff. And we have known for some time that one of the reactions to non-pulsatility is sympathetic stimulation and hypertension. And because of that, we were missing hypertension in the early experience with this technology, because you cannot measure the blood pressure with a conventional cuff if the aortic valve isn't opening. And I believe those strokes, those hemorrhagic strokes, were induced by hypertension that was not being properly detected because we weren't using the proper methods for detection. We're much more aware of that now, and we are much more attuned to actually managing the blood pressure. We measure the blood pressure with a Doppler, which allows us only to measure the peak pressure. It's not a mean pressure, it's just a pressure in the system where the blood first comes through. And it is, though, very helpful, and we try to maintain that pressure between 80 and 120 in the normal range. It does require continual, ongoing afterload reduction therapy. That is, the same heart failure therapy that the patient had before the induction of the pump, we utilize, but we utilize it in this case as a management for the hypertension, and to make sure that we don't get into the situation that would predispose the patients for having a stroke, particularly the catastrophic hemorrhagic strokes.